I've been asked to talk to you about vascular rings. And here I'd like to emphasize the importance of the development that I've shared with you in my previous presentations. Now, when we think about vascular rings, I hope you've all heard of the Rathke diagram, because it is the understanding of the Rathke diagram that underpins the way we approach vascular rings. And that has quite some history, because in fact, Rathke published this, as you see in the German literature, in 1857. Now, if you look at today's textbooks, and you want to know what the Rathke diagram looks like, you will find a picture that looks something like this. So let me explain to you what is going on here. Here we have the aortic sac. Now, I've already explained to you, the aortic sac is that manifold in the pharyngeal mesenchyme that, during the stages of human development, gives rise to the arteries that percolate through the pharyngeal arches. And here you see those arteries depicted in the Rathke diagram. And there we have the first 4 pharyngeal arches. But in the Rathke diagram, we then have this mysterious arch. You see that I put a question mark against it. You'll see there are dotted lines within this arch, because these are the arteries of the enigmatic 5th pharyngeal arch that so often is depicted nowadays in Rathke diagrams. And then, to complete the Rathke system, we have the ultimate set of pharyngeal arch arteries, and within the system, as usually shown nowadays, this arch is considered to be the 6th arch. We then have another key 2 players in this scheme, and these are the 7th cervical intersegmental arteries. And those 7th cervical intersegmental arteries, as we will see, eventually become the subclavian arteries. So this has been the basis for understanding now for well over 140 years. But let me take you back and let me show you the original Rathke diagram. So this is the diagram that Rathke produced in his original work in 1857. So count the arches that Rathke pictured. And there you see 1 through 4. And then look, we still have the 7th cervical intersegmental arteries. But what about this arch? Is it the 6th arch? And you'll immediately see it isn't, because in Rathke's original diagram, based on his embryologic researches, he found only 5 sets of pharyngeal arches. So, the basis of understanding vascular rings is indeed determined by the fact that the arch system initially is bilaterally symmetrical, but Rathke showed only 5 sets of arches. So where on earth did this impression that there were 6 sets of arches appear from? And in fact, it was Boas in 1887 making comparisons from other mammalian, avian, and reptilian morphology development, introduced the notion that there were 6 sets of arches, with the 5th set being enigmatic and disappearing during the course of development. But was Boas justified in making this change? So let me share with you again the evidence that we now have from human development with regard to the development of the pharyngeal arches. So here we are, very early in development, 30 days. We're at the beginning of the 5th week of development. As you know now, this is what we call Carnegie stage 12. I'm showing you a picture of the developing embryo from the right side and you will recognize to your right hand the developing head of the embryo. And there is the first pouch that grows out from the pharynx and which will be one of the borders of the pharyngeal arches. And the first pharyngeal arch is cranial to that pouch, and as you see, arising from the aortic sac, percolating through this arch on the right side, we have the artery of the first pharyngeal arch. We then can see the second pharyngeal pouch, and so the second arch is demarcated by the first and the second pouches. And within that second pouch, we have the second arch artery. But development and remodeling is very rapid at this early stage of development. So here we are, 30 days, Carnegie stage 12. We can move on one stage, and as I told you in my introductory presentation, a Carnegie stage is equivalent to about 2 days of development. So now we're in the 32nd day. Again, we're looking at the embryo from its right side. Those pebbles that you see to your left hand are the developing somites, and you will still recognize the first pharyngeal pouch. But in consequence of the remodeling that has taken place, we have lost the first arch artery. We still have the second pouch, we still have a dominant second arch artery, but now we've had formation of a third pouch. And there, percolating through the third pouch, we have the third arch artery. And although as yet we don't see a fourth pharyngeal pouch, already we see that there is formation of a fourth arch artery. So, Carnegie stage 13, 32 days, we move on one more stage, and this shows you how rapidly the changes are taking place. We're at the end almost now of the 5th week of development, and still we recognize the first pouch. We saw that the artery of that pouch had already disappeared at Carnegie stage 13. There is the second pouch, and now the second arch artery has disappeared. So what do we have left? We have the third arch artery percolating through the third pharyngeal arch. We now have formation of the fourth pharyngeal pouch, and there we see the fourth arch artery. But now we have formation of yet another arch artery, but we're never going to get formation of a further pouch. So the ultimate arch artery is the artery that will percolate on both sides through what we can now call the pulmonary arch, because it is that artery from its caudal border that will give rise to the pulmonary arteries. So there are only 5 pharyngeal arches formed during normal human development, as in fact Rathke showed in 1857. So Boas was wrong when introducing this notion of a vestigial 5th arch. So eventually I'm going to talk to you about those alleged 5th arch arteries, but first let's look at how the 5 sets of arch arteries remodel and how that underscores vascular rings. So I'm going to start at this stage of Carnegie 36 days of development, when we have the final 3 sets of arch arteries. So I'm showing you here the right horn of the aortic sac, and there is the left horn of the aortic sac. And on each side, cranially, the horns of the sac give rise to the 3rd arch arteries. Caudally, from the horns of the aortic sac, we have the 4th arch arteries. And at this stage, on both sides, we still have a dorsal connection through the carotid ducts. You'll see that already at this stage, however, the right-sided dorsal aorta is smaller than the left-sided aorta. And the feature of remodeling is this diminution in size of the right-sided components. Here is the seventh cervical intersegmental artery, as shown by Rathke in his initial diagram. And as you see, initially that starts off caudal to the point at which the two dorsal arteries fuse together. But that is going to move cranially. In fact, it's the heart that moves caudally, but there is going to be significant migration of the seventh cervical segmental artery on both sides. Here are the pulmonary arch arteries, and you will see that from their caudal border, they are giving rise to the right and left pulmonary arteries. And you can also note that already there is diminution in size of the right pulmonary arch artery. Again, it is the left-sided vessels that become dominant. So if we move on 2 stages, and here we're at the end of the 6th week of development, we're looking at the reconstruction now from behind. And so there you see the right horn of the aortic sac. And now it's giving rise to the right third arch arteries, and that is going to become the right common carotid artery. It then continues as the right fourth arch artery, which connects to the right-sided dorsal aorta, which continues to diminish in size and feeds the right cervical intersegmental artery. And these parts are going to remodel to form the right subclavian artery. Note that the right pulmonary arch artery continues to diminish in size, and the left-sided dorsal aorta becomes increasingly dominant. The left seventh cervical segmental artery is now moving cranially along that dominant left dorsal aorta, and the left pulmonary arch artery is also becoming dominant. But on the left side, the left horn of the aortic sac is feeding the left third arch artery and is continuing as the left fourth arch artery. So let's move on again. Another stage. Now we are at the beginning of the 7th week of development. I'm showing it to you now from the right side. So I hope you will recognize the intrapericardial aorta. As it exits the pericardium, it gives rise on the right side to what was the right horn of the aortic sac. We can now recognize that as the brachiocephalic trunk. And that gives rise to the right common carotid artery, the third arch artery, and look what is happening to the right seventh intersegmental artery, because it is now linking up through the right fourth arch artery to become the right subclavian artery, with ongoing attenuation of the right dorsal aorta. If we look on the left side, again, we have the left third arch artery forming the left common carotid artery, and whereas on the right side, the left seventh segmental artery will eventually become the subclavian artery, you note now that it is nearly opposite the left fourth arch artery and also opposite the left pulmonary arch artery, which will become the arterial duct. And that is continuous proximally with the pulmonary trunk. The right and left pulmonary arteries arising now from the caudal margin of the aortic sac. So by the end of the 7th week of development at Carnegie stage 22, we have the definitive situation. The intrapericardial aorta again now gives rise to the right horn of the aortic sac, which is the brachiocephalic trunk, feeding right common carotid artery through fourth arch artery, the right subclavian artery, which now has migrated up, having started as the seventh cervical intersegmental artery. The left horn of the aortic sac is now the first branch of the aortic arch, and it is giving rise to the left common carotid artery. The left fourth arch artery is the next segment of the aortic arch, and now you see that the seventh cervical intersegmental artery on the left side has continued its cranial migration. It is now passed across the origin of the left pulmonary arch artery, which we can now call the arterial duct, arising from the pulmonary trunk, so that part of the arch between the insertion of the duct, the origin of the left subclavian artery, is the isthmus. And so here, by the end, 7th week of development, we have the definitive arrangement that we see in the neonatal infant: aorta giving rise to brachiocephalic trunk, the arch then giving rise to left common carotid subclavian artery, continuing as the isthmus, the arterial duct being the continuation of the pulmonary trunk, which at the margins of the pericardial cavity branches to give the right and left pulmonary arteries. So we can put all of this into context now of normal development. So how does that relate to vascular rings? Well, in abnormal circumstances, those bilateral primordiums can persist. And a long time ago now, the doyen of cardiac pathologists, Jesse Edwards, pointed out that we could create a hypothetical double arch on the basis of these bilateral primordiums. And on the basis of the hypothetical double arch, we can account for almost all variations that we find in terms of vascular rings. I'm not going to be able to show all of them to you, but I can show you how we can use the hypothetical double arch to explain what is going on in terms of vascular rings, but not only vascular rings. It also accounts for almost all the examples of isolation of the brachiocephalic arteries, either the brachiocephalic trunk, the right common carotid, the common carotid arteries, or the subclavian arteries. So how does it work? Well, this is Edwards' hypothetical double arch. You see, the aorta in the hypothetical situation branches to give a right arch and a left arch. The two arches come together dorsally to form a neutral descending aorta. And you'll immediately see that they are encircling the tracheo-esophageal pedicle. From each arch, we have first the origin of a common carotid artery, and then the origin of a subclavian artery. And from the underside of the arches, we have an arterial duct. And in fact, we can see that in the basic forms of double aortic arch. So here is the nicest example I've got of a double aortic arch. We're looking down on it from above. So there is the aorta. Right arch, in this instance, is not dominant, but it gives rise to a right common carotid, a right subclavian artery. It is the left arch here that is dominant. In most instances, in fact, it is the right arch that becomes dominant. But in this particular example, the dominant left arch is giving rise to a left common carotid artery, a left subclavian artery, and a left-sided arterial duct. I have never seen an example with bilateral arterial ducts. So this is the closest I've ever seen to Edwards' hypothetical double arch. But what it shows you beautifully is how tightly the double arch clasps the tracheo-esophageal pedicle. And this is the problem that we have with vascular rings. It is, of course, the strain, the stricture that puts on the esophagus. But there are many variations. How do we explain them all? Because it is rare, as you have seen, to find the complete hypothetical arch, but the arch can be divided at any of its junction points. So it can be divided in the proximal aorta. It can be divided between right common carotid, right subclavian artery, or it can be divided distally to the right subclavian artery. Then, of course, we may not have a right-sided arterial duct. And we have exactly the same on the left side. So the left arch can be divided proximally between the common carotid and subclavian arteries, or dorsal to the subclavian artery, and there may or may not be present of a left-sided arterial duct. And it is where we find this loss of continuity that explains the various types of vascular ring. So let's look at the obvious example, which is when the double arch is divided between the right-sided common carotid and the right-sided subclavian artery. So then it is the dorsal part of the right aorta that persists, giving us the diverticulum, that then feeds the right subclavian artery, and we have a retroesophageal right subclavian artery. And that is what you see here in this exquisite computed tomogram shared with me by Tony Levarchek, who works in the Medical University of South Carolina. For many years now, Tony has been promoting the value of computed tomography. Now, using computed tomography, you can see what is going on just as easily as Diane and I can when we have the hearts in our hands. And this shows you exquisitely the essence of the retroesophageal right subclavian artery. So arising from the left arch, we have the right common carotid artery as the first branch, continuing as the left common carotid artery, the left subclavian artery, and then we have the right dorsal aorta as Pomerle's diverticulum, giving rise to the retroesophageal right subclavian artery. And you see it there in Tony's computed tomogram passing behind the esophagus. We can also, on the basis of a hypothetical double arch, explain mirror-imaged branching of the aorta with a right aortic arch. So there is our right aortic arch. And of course, the first branch now is a left brachiocephalic trunk. I picture here a right arterial duct. The system represents the disappearance of the left-sided dorsal component of the left arch. So it's gone, and this is the essence of mirror imagery, and in this instance we do not have a vascular ring. But should the left-sided arterial duct persist, then we can have a vascular ring. And in fact, the situation where we have right arch with left-sided arterial duct is probably the commonest form of vascular ring. So let's look at that in the setting of the hypothetical double arch. So there is our right aortic arch. It's giving rise to the right common carotid, right subclavian arteries. There is the proximal part of the left arch forming the left common carotid artery, but the double arch has broken between the left common carotid artery and the left subclavian artery. The the left dorsal aorta is now persisting as the diverticulum of Pomerle, and that is giving rise to the left subclavian artery. Why now do we have a ring? Because we have a left-sided arterial duct that is continuing down and inserting into the left pulmonary artery. So here is what it looks like when we see it in the autopsy room. There is the aorta, and its first branch is the left common carotid artery, and it continues as a right aortic arch. There is breaking of the double arch between the left common carotid artery, the left subclavian artery, and on the left side we have the pulmonary trunk containing a left-sided arterial duct. So if I turn the specimen so that you can now see its left side, There you see the left-sided arterial duct. You see it's arising from the pulmonary trunk. And now you see how it is continuing dorsally to join the descending aorta. So there is the left dorsal part of the left arch feeding the left subclavian artery. And there you see it encircling the esophagus, which is why we have a vascular ring. But it's a very loose ring, because in this specimen there is a long distance between the left subclavian artery, the left common carotid artery, which is where the hypothetical double arch has been broken. If we look at it from the top, we can see that again. The first branch of the aorta is the left common carotid artery. We have a dominant right arch, which gives rise to right common carotid, right subclavian artery, continues as the descending aorta. And then we see the dorsal component of the left arch, giving us the diverticulum of Komarov, and then the left subclavian artery. In fact, we've removed the esophagus now to take this picture, but with the arterial duct, we have a ring around the tracheo-esophageal pedicle. And there you see the space that would have been filled by the complete double arch. So the tightness of the ring depends on what is going on in that space. So in showing you the pictures thus far, I've shown you the situation in which there has been total disappearance of those segments of the double arch. But what happens if those segments persist as atretic fibrous strands? Then the rings will be very much tighter, and any of those segments can persist as a fibrous cord. And we know that in terms of the arterial duct, because we know that often persists as the arterial ligament. So the same can go for those other components of the potential ring. So let's return to the picture I've shown you already: pulmonary trunk, arterial duct, left subclavian artery. What happens if the segment of arch between the left subclavian artery and the left common carotid artery persists but becomes fibrous? Then the ring encircling the tracheo-esophageal pedicle will become that much tighter. And here is a picture showing you that situation where we have a tight ring reflecting the presence of these atretic fibrous segments. One formed by the arterial ligament, extending from the left subclavian artery to the left pulmonary artery, but then the presence of the second ligamentous remnant joining together the left subclavian and left common carotid artery. And it is very important when the surgeons go in to relieve these rings reflecting the presence of potentially these fibrous remnants, that they remember that not only might there be a fibrous arterial ligament, there can also be a ligamentous remnant of that component, the left arch, between the left common carotid artery, the left subclavian artery. And a variant of this is found when we have the so-called ductal diverticulum. That, of course, is representing Komarov's diverticulum, but again, in this variant of the ring, we can have both of these fibrous remnants. We shouldn't presume that there is only the left-sided arterial ligament. There can also be that fibrous strand joining together the ductal diverticulum, representing that atretic part of the double aortic arch. Now, I've explained to you that the double arch hypothesis also accounts for isolation of brachiocephalic arteries, and here we see it in the setting of the isolated left subclavian artery. So we have a right arch, we have a left common carotid artery, there the left subclavian artery, but the double arch has broken between the left common carotid artery, the left subclavian artery, and also that dorsal part of the left arch itself has disappeared. And now, with the left-sided arterial duct, the left subclavian artery is fed by the left pulmonary artery. And here we see an example of that arrangement. Looking at it from the left side, we see the left common carotid artery, and there is the left subclavian artery fed via the arterial duct from the pulmonary trunk. So the double arch has broken between the left common carotid, the left subclavian arteries, and the dorsal part has also broken, isolating the left subclavian artery. And on occasion, as you see in this beautiful specimen, we can have isolation of both subclavian arteries. So here is the ascending aorta, which is giving rise to the right and left common carotid arteries. This initially was a double arch, but the dorsal part of both arches has now disappeared. So the pulmonary trunk is feeding the right subclavian artery through the right arterial duct and the left subclavian artery through the left arterial duct. And note that constriction between the pulmonary trunk and the left pulmonary artery, that is so-called ductal coarctation. So showing us how we can explain all the variants of isolation of the brachiocephalic arteries, but I should say almost all, because in some instances we find that the duct cannot be in two places at the same time. And so it is Jörg Manner who has pointed out that in very rare instances we need to take into account the malseptation of the aortic sac, so to explain the situation when the arterial duct cannot be in two places at the same time. And he first published this in 1997. Very recently, he has updated this concept involving abnormal septation of the aortic sac. So I've not said anything at all yet about the so-called fifth aortic arch arteries. Why? Because there are only 5 pharyngeal arches. And in fact, it is the arteries of the pulmonary arches that are the true fifth arch arteries. But we can no longer use that term because the literature of pediatric cardiology is replete with lesions interpreted on the basis of persistence of a fifth arch on the basis of a set of 6. So how do we explain those variants? Well, in most instances, as you see here, where we have left, third, and fourth arch arteries and the left pulmonary arch artery, we have a collateral channel. And those collateral channels are found in almost half of all mouse embryos. And that explains double-barreled aorta. We found one human embryo that quite some time ago we thought was a fifth arch artery. So here you see the left horn of the aortic sac with fourth arch, fifth arch, and left pulmonary arch arteries. We now believe that this vessel again is a collateral channel. So in fact, now it's our belief that the lesions previously interpreted as though there were 6 sets of arches and we had persistence of the 5th set, we now believe it is much better to interpret them on the basis either of abnormal remodeling of the aortic sac or because of persisting collateral channels. There's another lesion I have to mention, which is the vascular sling. And the vascular sling, of course, is when the left pulmonary artery takes origin from the right pulmonary artery and inserts itself between the trachea and the esophagus. And this has nothing to do with remodeling of the vascular system. This is a malformation of the trachea, and that is why so often we have complete tracheal rings. So, ladies and gentlemen, what I hope I've been able to do is to provide you with a rational explanation as to how all of those vascular rings can be based on the knowledge of the Edwards hypothetical double arch. I've shown you only 1 or 2, but the myriad variations can be interpreted on this basis. Vascular sling is abnormal tracheal rather than vascular development. And as I've said, we only have 5 sets of arches. So those rare lesions that you might consider fifth pharyngeal arches are far better explained either as collateral channels or because of remodeling of the aortic sac. But again, I'm more than happy to discuss all of this if you have any questions or comments. Thank you for permitting me to join you.
All right.
Is there a question in the chat?
Yeah, I was just waiting for the nod, but I'm unmuted. Okay, great. So we have some questions in the chat as well in the room. This is a question from Dr. Godino. Quote, during development, what are the signals that prompt the left-sided dominance and the diminution of the right-sided arteries? Besides genetics, are there dynamic pressure changes, etc., with the development of the left heart circulation?
That's an excellent question that I do not have the answer to. I'm not sure that anybody knows the answer to that. It's a very good question. I would presume that there are going to be some genetic switching on and switching off that are going to underpin the changes, because there are marked remodeling. And remodeling certainly involves changes in the morphologic makeup of the right-sided arches, but I've not even really thought about that. I'm not sure anybody else has thought about it. Certainly flow is also going to be important, and there's a lot of evidence invoking the flow patterns in expediting, if you were, the remodeling of the different passages. But I'm sure the genes must also be involved. So if you asked me, I would say it was a combination of the genetic background coupled with abnormal flow. But I say that totally off the top of my head.
Thank you. Well done.
Professor Anderson, do you see any correlation between the presence of the commerce diverticulum and a persistent duct or ductal ligament?
I think Van Meerop was the guy who said you only ever get a commerce diverticulum when at some stage there had been flow through an arterial duct. And I think that does hold good. So Van Meerop did a lot of work on vascular rings and slings. He also did some very elegant work with his colleague Lynn Pucci. And they published quite extensively on this, so probably 30 or 40 years ago now. And so Van Meerop, I think, made that important point where you see commerce diverticulum, you can presume that there had also been at some stage an arterial duct on that side, and so you should anticipate that there is going to be an arterial ligament again. And I think that holds good. I think it's a very good point to make about vascular rings.
Questions? I'll say I found your comments about the apparently erroneous terminology for persistent fifth arch to be interesting. I'll highlight, I've heard on more than one occasion your friend Andrew Reddington diagnosed patients with persistent fifth arches. So I look forward to you telling him his error.
I've diagnosed it myself. I've written a whole chapter in the first edition of our textbook describing the fifth arch artery. When the new evidence comes to light, we have to take note of it. And this is work I've been doing over the past 4 or 5 years. There is an excellent molecular biologist who works at Guy's Hospital in London who's called Anthony Graham. And he made contact with myself and Wout Lammers. And Wout Lammers is the guy who, with Jill Hickspoos, produced all the exquisite reconstructions I've been showing you throughout my presentations. I should have mentioned that. It was remiss of me not to do that. So Wout and Jill and I worked with Anthony Graham, and there is no question that the reconstructions of the human embryos show there are only 5 pharyngeal arches. So I've had to eat my own words and accept that we can't explain an abnormality of something that has never existed. And when I now think about it, it's much easier to account for all of these on either remodeling or collateral channels.
Very interesting.
One more question. Professor Anderson, how commonly have you seen this entity of circumflex aortic arch? There's lots of surgical literature about it. We also recently performed a procedure for it. So our patient had a right-sided aortic arch and a left descending, and a ligamentum and a ductus remnant that completed the arch.
I've never seen a circumflex arch. I know about it, I've read about it, but I've never seen one. Diane, have you ever seen the circumflex arch?
Yeah, they have one at Lurie, and I have seen them at our clinical conferences once or twice on CT.
And this is the point I made during my talk. I think that now you as clinicians, you see these things so much better than we do. I think what you see with CT now is quite and magnetic resonance. I shouldn't do magnetic resonance. But I think that for me, the resolution that you now get with computed tomography is absolutely exquisite. And as Diane says, you now pick up these things, and it's so much easier to see. Diane will tell you, in the past, goodness knows how many of these things we destroyed when we were dissecting them because we weren't anticipating them. And that you now have to be very careful doing that, Diane.
Yeah.
All right, well, thank you so much, Professor Anderson. I think we have one video left from you tomorrow during our functional univentricular heart session, but this has been really amazing.
And I think this later today, Diane is going to be showing you heterotaxy, is she not?
Yeah, we have, so I think next
You
up,
mean isomerism?
Isomerism, absolutely. So I will join you I will come back and I'll join you for the isomerism session, even though it's called heterotaxy, because Diane, I'm showing you some spectacular specimens. So it's been a pleasure to be with you all. I think that again, I would say you have seen quite spectacular demonstrations by Diane. The material she's been showing you is awesome. Jeff Jacobs would say it is awesome. So she's doing a great job with you, and thank you for having me join you from London. It's much easier for me to sit in my sitting room, but I'm not going to be able to enjoy the Pinot Noirs that Diane is going to enjoy as she goes to all the wineries. So I envy her for that, but thank you for letting me join you from London.